Hi, and welcome to Houston Methodist and DeBakey CV Live. My name is Marvin Atkins. I'm one of the cardiac and vascular surgeons here at Houston Methodist. And tonight I'm joined by two esteemed colleagues, Dr. Michael Reardon and Dr. Thomas MacGillivray, who are experts in the world of aortic surgery, have been treating patients with aortic dissection for many years, and we're all going to enjoy their perspective on the management of type 1, type A aortic dissection. This evening, we'd like the audience to participate, and we have a couple options for you to submit questions that we can answer, hopefully online here. One of those is by the web. You can go to pollev.com and enter in DeBakey, and then you can respond to the activity at that point, ask us questions throughout tonight's presentation. Or you can text us, and the easiest thing there is to text DeBakey, D-E-B-A-K-E-Y, to the number 37607. This evening, what I was hoping that we would do is kind of present a few cases of aortic dissection, a couple of the different unique malperfusion syndromes, some unique scenarios, and see if I can stump some of the experts in the management of type A dissection. Gentlemen, thank you very much for joining us this evening.
Thank you, Marvin.
Hey, Marvin. Great to be here.
Great. All right, so we've got the first case. So this was a 76-year-old female. Her past history is significant for hypertension, hyperlipidemia. She has coronary disease, previously had a PCI to her LAD back in 2007, and she has a known ascending aortic aneurysm measuring 4.7 centimeters back in 2019. And she presented to the emergency room with the acute onset of severe chest pain, starting about 6 hours prior to her showing up in our ED. On arrival, she was quite hypertensive, 168/72. Her EKG was unremarkable. Her chest x-ray had a widened mediastinum. She was pretty comfortable in the ED. She did not seem an extremis. And given that history of a thoracic aortic aneurysm and the acute onset of chest pain with a normal EKG, normal troponins, she underwent a CT scan of the chest. All right, so here is the axials. Hopefully this will play, if you can see that. So you can really see an intramural hematoma involving the ascending arch and descending thoracic aorta. You also see that abnormality within the ascending aorta. And then her root extending down to about 4.7 centimeters. And here's a better shot. So in the mid-ascending aorta, there's an abnormality there. And so really there's no dissection flap. This is truly an intramural hematoma. It extends all the way down her descending thoracic aorta. So gentlemen, the management of IMH. So this is a patient, again, with a penetrating ulcer of the ascending aorta. She's got an acute aortic syndrome in the setting of a pre-existing 4.7 centimeter ascending aortic aneurysm. What are some of our options for repair? We've got open, we've got possibly even an endovascular approach. Dr. Reardon, you're up first.
Well,
Thoughts?
I think the first thing you really need to look at, Marvin, is what do you think the overall risk to the patient is? I mean, if they're a relatively good surgical risk, that's still a gold standard for this. And to me, a penetrating ulcer with a hematoma like this going all the way down is a dissection till proven otherwise. Right. And when we get in there, you'll find a flap that you're just missing. At least that's been my experience. So if they're a good surgical risk, they're going to need surgery. If they think they're a very poor risk, then we would evaluate them for stent grafting.
Okay.
Yeah, I think our thinking about intramural hematomas have changed over the last 20 years. It was thought to be something you could watch and medically manage and just manage their complications. And I think there's been a lot of good data that's come out to show that they actually are they're an aortic dissection, and that they should be treated as such. So I think the conventional thinking now is that if you have a type A IMH, you treat it like a type A dissection. If you have a type B IMH, you treat it like a type B aortic dissection. And I think that penetrating ulcer in the ascending aorta just kind of adds some more urgency to it.
Right. Okay. So if you're going to repair this, how are you going to repair it? Open hemiarch, clamped ascending, some type of more distal operation? How would you treat this?
Well, I never clamp the aorta when I'm doing a dissection unless I'm clamping a part that I'm going to take out later just so I can start, on the proximal end. I always do it open. how far distal you go, to me, really depends on what you see in the arch. If the arch is normal size, there's no tear in the arch, no, I just do a hemi-arch on this. Obviously, if there's a tear in the arch or the aneurysm extended the arch, you would go as far distal as you need to go to fix this. But I have a pretty standard way I do these. I do axillary cannulation. I cool them all for 30 minutes. I'm an old-fashioned guy, and I do an open distal repair. If they had AI to begin with, yes, I'd clamp the mid-aorta. I would cardioplegia, start retrograde and go right down the corners if need be, and start on the proximal end while I'm cooling.
Cooling distally. How cold would you go?
30 minutes, which usually gets me down to 22 to 23.
Okay. All right. Presumably, since we see this abnormality in the mid-ascending, presumably that's the entry tear, Tom, by imaging?
Presumably, yeah. I think to Mike's point, I think it's very important to get a very good look inside the arch. And I think in the imaging that we have, and the imaging is pretty good these days,
yeah.
but still, one of the benefits to doing these with an open technique is you can inspect literally the aortic arch. And in the absence of a tear or in the absence of an aneurysm, I think just doing a hemi-arch replacement.
Okay. Is there a role ever for RCP in these cases and dissection in your hands?
I don't ever do retrograde cerebral fusion. I always do antegrade cerebral fusion, so I cannulate the right axillary artery. I will typically get out the base of the innominate artery, and if I'm under 20 minutes, I generally don't worry about it. If I start going above 20 minutes, then I'll usually flow 1 liter to 1.5 liters antegrade up through one side. I don't think you necessarily need to do both sides, and that has served me well. I have many friends right next door at UT Herman.
Sure.
Dr. Safi did a lot of retrograde, and Tony Estrella now does retrograde. Lynn Girardi up at New York Presbyterian does a lot of retrograde. I just think that blood was meant to go antegrade, so that's how I put it in.
Tom, is there ever a role for RCP in dissection?
Yeah, as Mike said, I think that there's a lot of airtime between experts, whether you should do ACP or retrograde or both.
Yeah.
I think that the data between those two isn't very clear whether one is superior to the other. But I think one thing that's becoming more and more clear is you should use something.
Yeah.
That you should do some kind of protection. So, and you do well to do what you do well. If you do a lot of retrograde cerebral perfusion, that's a good technique. If you do a lot of antegrade perfusion, that's a good technique. But I think if you don't do anything, you should adopt one of them.
Yeah.
Because I think that if you have a very short circ arrest time, well, I think that's probably okay. But unless it's very, very short, in my experience with these operations is sometimes you can't
tell what you're going to get into.
What you're going to get into. And by the time you realize that you're into something, it's too late to
30 plus minutes there.
To change horses in midstream.
Yeah. I have my perfusionist click off every 5 minutes as we're on circ arrest time, 5, 10, 15, just to remind me how long we've been there, because I tend to zone out and forget. And that way I know if it starts, if it clicks past 15, my attention now is up to, okay, what do I need to do?
Gotcha. If the patient presents with frank rupture, and so they're unstable, they look like they have tamponade by echo, you're in the operating room, does your cannulation strategy change at all?
Well, if they're hypotensive, you're going to have to get them on bypass as fast as you can, whatever is the quickest way you can get them on bypass. And if that's femoral bypass, that's what you really need to do. I see a fair number of people with a big hematoma and they're hemodynamically stable, and I will also cannulate the axillary artery in the femoral vein. And that's a fairly simple thing to do before you ever open the chest. Because I actually sew my graft on with no heparin, so it's really pretty easy to do.
So I think if somebody's hemodynamically unstable, at least my approach to that is to get the chest open, and if
relieve the tamponade.
with the hope is that they're hemodynamically unstable because of tamponade.
Yeah.
If they don't get better by relieving the tamponade, that brings you down a different pathway, and that prognosis of that patient is very concerning. If that's the case, then my strategy for that would be to directly cannulate the aorta.
Yeah.
And then you can still do antegrade cerebral perfusion. You can put the cannula when you do a brief period of circulatory arrest. You can stick the cannula in the innominate artery and put a tourniquet around it and flow that way. But I do think that there is a good role for direct aortic cannulation in a patient like that.
So what I've typically done is, at least in my arterial line, I will usually put another 3H connector with a side stopcock that I can then put an octopus, and I can then put whatever balloons up that I need to, those little perfusion balloons, and perfuse if our SATs drop on the left or there's no blood coming out of the left side when I'm perfusing antegrade on the right. Do you typically what's your strategy in terms of your arterial line setup for multi-vessel branched perfusion?
So what I do for any kind of arch case, dissection or otherwise, I'll put a Y connector in the arterial line. And one limb of that Y connector will go to the axillary cannula if that's what I am using, or if I'm directly cannulating, it'll be to the aorta. And that gives me the ability to, if I'm doing integrate superperfusion, when I sew my distal anastomosis, I can reestablish flow distally, or during ACP, if I have either a drop in the somanetics, or I have if we're using TCD and see flow is disrupted, I can use that other limb and put it up the left carotid. I mean, I routinely use unilateral ACP unless there's a reason that the flow is not very good. And that, I have to say, like in the literature, I think that's very, very uncommon that I have to cannulate the carotid, the left carotid.
Do you make it a point of digging out the left common carotid, making sure there's blood coming out of there, and then clamping the base of that so that it's all going antegrade and you're not losing it as a sump?
So yeah, what I do is I do a brief period of circulatory arrest while I get control of the arch vessels, all three of them. Then I start integrate perfusion up, and I'll clamp the innominate and then look at flow coming out of the left carotid. And if it's good flow, that makes me feel better. I'll clamp the carotid, and then I also control the subclavian either with a clamp or with a Pruitt catheter.
Okay.
Whether it's necessary or not, I don't know. Whether it makes the patient better, I don't know. It certainly makes me feel better.
Mike, for your hemi-arch operation, do you typically dig out the head vessels and occlude those?
The innominate and the left carotid. Unless I'm actually going all the way around the arch and replacing the whole arch, I just leave the subclavian alone.
Yeah.
Okay.
I typically will do my distal anastomosis without any flow because there's no backflow coming in. Usually you can get that done in 10-15 minutes, and then I start flowing. I do find it somewhat aggravating if you don't have them clamped.
Yeah.
Sure. All right, so we talked a little bit about cardioplegia strategy. If the patient has AI, obviously you're going to start off retrograde and then open up the ascending and then give direct osteal, arrest your heart.
I think, as Bruce Lytle used to say, if you protect the heart and protect the brain, you can take whatever time you need to do the operation that the patient needs. If you're not going to protect both, then there's no reason to.
I will say on those that I don't need to clamp, I just need to cool. I put a retrograde in everybody, and then I give them retrograde. And if they, I don't give them antegrade, unless I have to clamp it and give them antegrade. When I learned to do this under Dr. Cooley, he just cooled them and gave them nothing. It never really sat well with me. Why not protect the heart as well as you can, even though you're cold? And flushing out with a little bit of retrograde cardioplegia always made sense to me.
Tom, have you been giving Del Nido lately in terms of your cardioplegia up front instead of?
So I do use Del Nido now, and I think it's a very good myocardial protection strategy.
Okay.
And it saves some time in not having to give it every 15 to 20 minutes. You have to remember to give it after an hour or so,
Sure.
but it's a very good cardioplegia in my experience.
Okay. Next question. So how do you handle the distal anastomosis in terms of an IMH? So you've got that big, thick hematoma that's there distally. Do you try and take any of that out, put felt in there? How do you try and construct your distal? Either way.
Well, I sew it with a 4-0 and then do plated 4-0s all the way around it. I usually don't use felt strips, which is a little bit of against most of the guys I grew up with. Most of them do use felt strips, so I'm a little bit of an outlier. But I found that that's actually worked pretty well with me. Now, I would never say never about anything.
Sure.
If I thought the tissue was bad enough, then I would use either inside or outside or both. But most of the time, I just sew it with a 4-0 and then put in plated 4-0 stitches around it. And then I crank up the flow and look at it and make sure that it's looking okay before I sew anything else.
Tom?
Yeah, so I was trained to put felt on the inside, felt on the outside, and you basically used a baseball uniform to fix these aortas. I don't put anything on the inside anymore. I commonly use a felt strip, Teflon felt, inside the false lumen, and use a 5/0 to sew that in and to re-establish the 3 layers. And then I'll use Proline, and I'll take a strip of the Dacron graft and use that instead of a felt strip. I find that works really well. The problem I always had with felt on the outside is when it gets wet, it gets soggy. When it gets soggy, the sutures become loose, and then it starts to bleed. That doesn't happen if you use a piece of the graft. It works pretty well.
Yeah, what we did at Penn, where I trained, is that we would take a little bit of the hematoma out. We would take a felt strip, put that in the false lumen, baseball stitch all the way running around, and then we did an inlay anastomosis of where you're taking big bites of graft, big bites in the aorta, and you get the graft to sit inside by a centimeter or so, and you get that to press out and seal.
Yeah, I would say, like we said before, find what works for you. Use what's worked, and take the time you need to do it right. Yeah. People get nervous or in circle rest, they work fast. There's nothing worse than cleaning up at the end. Right? Take the time you need to do it right the first time. Yeah.
So let's go to the other end. So what about now going into the root here? How do you like to handle either a dissection or an IMH going into the aortic root, that's dissected the root? How do you like to handle that? Do you try and just resuspend things alone? Do you try and put felt down into the new sinuses? Do you routinely go to a Bentall, valve-sparing route?
So I think it's important to really take a good look at the root. You have to look at what the valve, the condition of the valve, the size of the root, and the condition of the root. So if there's a valve that is calcified and has organic disease, I have a low threshold in a situation like this to take that valve out. If the root is dilated, if the commissures are torn off, and certainly very important is the condition of the patient, I'd have a low threshold to replace that root. Oftentimes that's a faster, more safe way to manage that patient. If the patient's stable and the root is looks like it's reconstructible, I think either using the neomedial technique or in some younger patients, I also will do a valve-sparing root in a dissection. I know that's not the board answer, but I think in appropriately selected patients, it's a good operation. And it's a very hemostatic operation too.
What's your upper size limit of a root diameter that you would leave alone?
If it was 4.5 or less, I'd leave it alone. If it were bigger than that, I would strongly consider taking it out if the patient is stable enough to do it.
If you're considering a valve-sparing operation in a patient, would you do that in the setting of they don't have anything that you're going to have to do other than a hemi-arch? Or what if you had to do either a total arch or go further out? Would you then not plan on doing a valve-sparing, do you think? Or?
So, I don't. That doesn't sort of. I think with good brain protection and good myocardial protection, I don't think it really factors in.
Okay.
If it's an older patient, and I think you could argue that the benefit of a valve-sparing root over a bio root, it's probably a wash, and you can or maybe even favors a bio root, and it's just quicker and more reliable to do that. I mean, your worst nightmare, of course, is to go through the trouble of doing a valve-sparing root and having it not work.
Sure.
Having AI that you have to go back in and replace it.
What do you think is an age limit for valve-sparing root in the setting of an aortic dissection?
My age plus 2.
Yeah. well, then you're older if you come to me. Yeah, I think that's an important comment because when you ask what are we going to do, it's all contingent upon the patient you're looking at. If you're looking at a 75-year-old versus a 65-year-old versus a 55-year-old, we're all thinking different things. Once you get past 70 or 75, the valves we're going to put in there are going to last long enough, and these are typically going to be fairly good-sized valves, so even if they fail, we have non-surgical options for them. And as far as how much you have to do downstream versus upstream, those are two different organs to protect. One's the brain, one's the heart, and so I look upon those totally separately.
I mean, this is a very interesting discussion, but what is the most important to folks who are listening is aortic dissection is a very deadly disease. The prime goal of a dissection operation is to keep the patient from dying.
Yeah.
If you can do that and get fancy, good for you.
Yeah.
But you don't want to sacrifice the safety to do a valve-sparing root replacement or to do something fancy in the arch. I mean, the goal is to, if you look, in the IRAD database, the mortality is about 23%. So that's a pretty high bar to get over just to get the patient to survive.
And those are the patients that were selected for surgery, because 20 to 30% of people never were given surgery because they're turned down.
Right.
So I think that it's important to do what you know how to do, and to remember that we rarely cure these people. We just convert them from one type of dissection to another type of dissection. Right. And this is basically a palliative operation where you want to get them out of the operating room to fight another day. Yeah. If you do these every week, then you're going to do a different operation than if you do one every couple months.
Right. Right.
All right. So what size IMH of the ascending aorta would you feel comfortable watching, if any? I think we kind of briefly went over that, probably not.
I consider them all dissections. I mean, again, there's nothing in life that's an absolute. And so if I had an 86-year-old person with a small IMH, I might work them. But if I had a 50-year-old viable person, I have a hard time doing that. Those people can die overnight.
Well, I think Tony Estrella presented a few years ago at the aortic meeting the IMH experience, and I think what he nicely showed is that it takes an emergent operation, which is an aortic dissection, to an urgent operation. Yeah. And so you don't necessarily have to operate them in the middle of the night. You can do them the next morning. Although I have to say, like you, Mike, it makes me nervous to do that. Yeah. They get to sleep, but I don't. It makes me nervous.
Well, I have to tell you, Tom, when I get called about these, until I can lay eyes on them and fix them, I'm not going to sleep anyway, so I might as well come on in.
Right. All right. So this patient underwent a TE, had a normal ejection fraction, mild AI, very small pericardial effusion. They underwent axillary cannulation for ACP with an 8mm graft, LV vent, moderate hypothermia to 22 degrees, had retrograde arrest with a liter of Del Nido, had an open hemiarch anastomosis with a felt strip on the outside, resuspended the commissures at the sinotubular junction with some felt strips in the sinuses. The ACP time was 23 minutes, and the patient went home on postoperative day number 7. So that was a...
It doesn't get any better than that.
This must have been Tom's case. It sounds really good.
That's Marvin. It must be Marvin's case, I'd say.
Unfortunately, not even my case.
Oh.
All right, second case. So this one actually is mine. So 52-year-old male with reflux, obstructive sleep apnea. He's a pack-a-day smoker. Presented to the emergency room with kind of 2 days of chest pain. He described to us that he had, and I know this quite well, he had a 15-year-old daughter that was driving him crazy, and they got into some type of argument, and his blood pressure got really high, and all of a sudden he started having chest pain. He kind of wrote it out at home for a couple days before he came in. So when he came into the emergency room, his EKG had some non-specific changes. His troponin was negative. They up-titrated some of his blood pressure meds. His pain went away. Admitted him to the floor for an ACS rule-out. They got a cardiology consult. They actually got a stress test on him and an echo that next day. The stress test got done before they came to do his echo. Once they got his echo, his ascending aorta was enlarged at 4.3 centimeters. And because of this, they went ahead and they got a CT scan on him. If you look at the axillaries here, so he's got an isolated dissection, which will show up here in a second, really just in the transverse arch. So narrowing to his left subclavian, the ascending, and basically it stops right there at the innominate and stops right there in the descending. And then 4.3 centimeter ascending kind of came down to normal, and the rest of his aorta looked okay. If we look at the sagittals here, it'll show it pretty well. Again, really kind of starts at the innominate, extends over to the left subclavian, kind of torn in here. Not really dilated, ends right just past the subclavian with some narrowing of the left subclavian, and his descending aorta is normal. So the odd duck. All right, so we've got an isolated transverse arch dissection. His arch is not dilated. The ascending aorta measures 4.3 centimeters. And at this point, he's been in the hospital about 3 days and is completely pain-free.
Yeah. Well, to me, he's got a type B dissection, and we treat him as a type B dissection. He's got an uncomplicated type B dissection. He's pain-free. He should be on beta blockers. His blood pressure should be down. He should avoid his 15-year-old daughter for a couple months. And, you know, I mean, as long as it's past zone 0,
Sure.
to me, it's a type B.
Okay.
Yeah, I think the Europeans would refer to this as a non-A, non-B
Yeah.
dissection, and I think I do think that there is. The experts disagree.
Yeah.
In my opinion, there's no right answer,
Yeah.
only wrong answers.
Yeah.
And but I agree. I would
Yeah.
treat this as a type B dissection and treat it medically.
Yeah.
And unless there was some complication or hard indicator to proceed with an intervention.
Gotcha.
He's also kind of selected himself out already. He's gone several days
3 days.
before he ever saw you. So, that
Yeah.
to me is a hint that, you're on a fairly reasonable course if you can get his blood pressure down and treat him. Now, is he likely to come back and see you at some point? Yes.
So, is there an entry tear just distal to the subclavian? Is this
It's hard to tell.
a retrograde
hard to
extension
tell.
of a? Yeah, hard to tell.
I'm kind of hoping that the tear is beyond the innominate and it's going antegrade, because if it's at the subclavian coming retrograde, I'm a little more worried about him.
Okay. So again, we talked about do you operate or do you manage this conservatively? Say, for instance, we didn't know this 3-day period of him kind of self-selecting out and you're just seeing him in acute onset of chest pain. When are you going to follow him up with imaging, timing of that?
I'd check another scan in 2
Yeah.
days.
48
Yeah.
hours. Yeah.
Yeah.
That's typically what we do.
Before he leaves the hospital.
Yeah.
Yeah.
Okay.
And then I'd do it again a month after
Yeah.
he leaves the hospital.
All right. Well, so far, thank God, both of you agree with my plan here. So the initial plan was to manage him conservatively, repeat his imaging at 48 hours, get his blood pressure under control, and again, at 48 hours, he looks pretty good. And we actually, because he's young, we decided to get an MR on him. And again, just kind of look at the dynamic flow of this flap here.
Well, it almost
Trying
looks
to
like the
find some
tear really
clues.
is at the innominate and then going downstream.
Right at the innominate.
It looks like it's going
downstream.
antegrade down the false limb.
I think that's right.
So, there are all these risk factors that you can prognosticate. If there's a tear on the greater curvature just beyond the left subclavian, they're less likely to
Yeah.
retrograde dissect. If it's on the
lesser
lesser curvature,
curvature,
it's more likely. And I think also too, that's the good news. The bad news is if it's on the greater curvature and it's big, they're more likely to have malperfusion
Yeah.
syndrome.
Yeah, tell him to call me. I've raised 2 daughters. Tell me it'll get better. I promise.
All right, so MRA at 48 hours, no significant change since his original CT scan. We discharged him home on strict blood pressure control, smoking cessation. I saw him back at a couple months, so again with another MRA, no significant changes. I saw him back at a year, again since this initial dissection, again no changes. So of course he now comes back in at 20 months to the emergency department with recurrent chest pain following this initial dissection. He gets a CT scan in the emergency department, and now he's got a type A, or type 1 here at Methodist. So extends down to the root. If you follow the descending down here, his true lumen gets pretty small. He actually has a flap that goes out into the SMA and looks narrowed there. Renals look okay, comes down to the bifurcation, comes down to the iliac. And it looks like there's differential flow left compared to right. He actually does still have a faint pulse in the left leg here compared to the right. And we can look at the sagittals again. So now we've got kind of an acute-on-chronic, or an acute component, a chronic component, and then all this new stuff that's going down the descending, including a narrowed true limit.
How big's the arch now, Marvin? Do you know?
I don't remember
Looks
off the
like
top of my head.
That's good
It
up
looks
Looks a little bigger.
mid 4.5s, I bet. Maybe just
It
under
looks
5.
like looks like a complex
Tear.
septum in the arch. Yeah.
Okay. All right, so now we've got an acute type A dissection with a very complex chronic arch dissection. His narrowed true lumen in the descending aorta dissection now involves the SMA and the left common iliac. He has chest pain, back pain, but surprisingly doesn't have any abdominal pain. He's got a normal lactate. His left leg pulses are diminished. He's got a normal neuro exam. His echo shows moderate AI, normal EF. So what's your operative plan in this patient? Do you treat the descending aorta first? Do we do a hemiarch? Do we do a total arch? Do we do a frozen elephant trunk with that? Lots of different options. Mike, how would you handle this?
Well, the only thing I'd say is absolute is you don't treat the descending first, and then you can start making your decisions from there. You treat it as ascending, and however much of the arch you need, you try to redirect him back into the true lumen and see how he does. I mean, my kind of looking, it's hard to tell without being in there, but typically I'll go all the way to the subclavian. I'll window that septum as far down as I can because it's all chronic septum. It's going to be a piece of leather. Sew a graft on there and then deep branch the annulment and the subclavian upstream and then do whatever you need to do proximally. And then that gives you an opportunity to come back and do a TVAR later if you need to with a good landing zone. So essentially my version of a frozen elephant trunk. Nothing really going down the descending, but just a frozen distal graft.
Tom, how would you handle this patient?
Yeah, so I think, as Mike said, I think you have to treat the type A dissection first. And given the appearance of the imaging and his presentation, I would plan on replacing his arch in addition to his ascending. What to do with the proximal descending? I would err on the side of treating this as if it was a chronic type B.
Yeah.
I'd fenestrate it.
Yeah.
And because I think the trap you could potentially fall into if it's a chronic type B and you treat it, if you reestablish flow through the true lumen, you could exacerbate malperfusion syndrome. And I think the same thing I would worry about it if you did a frozen elephant trunk, because that would essentially do the same thing.
Yeah.
It would direct flow into the true lumen. You might get away with it, but you might not.
Yeah, so I guess the concern here was that this SMA was narrowed, and it's really not a dynamic obstruction at the aortic level. It looked like the dissection was static and went out into the SMA, although no abdominal pain, no lactate.
Right.
So I'm not sure a frozen elephant trunk or any type of aortic-based improvement of flow is really going to help with that.
So I think I mean, you bring up a good point. The difference between malperfusion and a malperfusion syndrome.
Yeah.
Right.
And I think that very commonly the imaging is so good now that you can see with high fidelity and clarity where the true and false lumen are. But I think what would, at least for me anyway, what would help dictate what approach is if he was clinically had malperfusion. And I would take comfort in knowing that his lactate was 1.4 and he didn't have abdominal pain. If he did, say his lactate was 7,
10,
and
make it really,
and he had abdominal pain, then I think, that would be, and my thinking on this has changed over the years, that would be somebody who I think you would want to manage the descending aorta first. Those are a very high risk group of patients for mortality by going after the ascending first.
Yeah. So there's a great paper in this month's Journal of Cardiothoracic and Vascular Surgery from the group at Michigan. I think Bo Yang's the lead author, but Michael Deeb and Karen Kim and the whole group there, looking at patients who present with malperfusion, where they're going in and they're, as they've done for the last 25 years, stenting open the true and false lumen, not doing a TVAR and doing balloon fenestration to try and equalize the pressures between the two lumen. And actually, over the last 8 years, the article says their mortality rate was 0. I think 7% for the decade or so before then.
I think they
unique
have
scenario there.
They're a great center of excellence, and I think they have a partnership between their cardiac surgeons and their interventional radiologists. And I think Dr. Williams is a very gifted interventional radiologists. So I think that's the patients in Michigan and the surrounding area benefit from his expertise. I mean, you do much more interventional stuff than certainly than I do.
More than me too.
But I mean, can you talk
Yeah,
about
so, I
the
mean,
difference between fenestration and putting a TVAR in?
Yeah, so I mean, fenestration, there's multiple different ways to do that. Basically, you can take any type of catheter, glide wire, and pop over from true lumen to false lumen. You can balloon that, you can stent across that. Sometimes if you can get a wire up the false lumen, a wire up the true lumen, connect the two, snare it, you can pull that down. One of the concerns about that is that you can get this big intussusception of torn septum that comes all the way down. Lots of different interventional ways to try and basically equalize, the goal of equalizing the pressures between the true lumen and the false lumen.
Do you electrify your wire when you do that?
Usually have not done that. I mean, we've done that with some basilica cases, using electric cautery on the back end of a wire to go through aortic leaflets, but I've never really done it.
I think we ought to start thinking about that because it makes a much cleaner cut than just
Does it?
dragging
And just poking through.
It really cuts it, doesn't tear it. Tearing it what gives you the intussusception.
Yeah.
I mean, I've taken the back end of a glide wire to poke through, but I haven't really, used it to cut. But that.
So
makes a
Marvin,
great
let me ask
point.
you a question. So this guy had a chronic descending and then this acute ascending.
Right.
Now, what if this had been an acute ascending that had a dissection that went around and some lack of perfusion to the SMA? Would you treat it differently as far as how you'd approach it, TVAR versus fenestration versus how you treat the true and false lumen?
Yeah, so if I had a patient that, DeBakey one dissection acutely all the way up and down, but their presentation is malperfusion to the,
They're clinical,
the viscera,
they
lactates up,
Yeah.
abdominal pain, but they're hemodynamically stable, they don't have tamponade, they don't have something that's pushing you to do the front end. In those patients, looking at the CT scan, I'm looking at to see is there a problem at the aortic level or at the branch vessel level. So is it dynamic obstruction at the aortic level and it's just a septum that's coming over that's compressing the true lumen, or is it that the dissection has gone out into each individual branch or one of the branches that you're concerned about, especially most importantly, I guess, the SMA. And is it, a big clot that's in the false lumen there that's compressing your true lumen? In those patients, I think it's reasonable to try and, TVAR the proximal end of the descending.
Yeah.
And, I'll usually cover them from the left subclavian down to the celiac to really try and reperfuse. We do have the option of the Cook dissection device now, where you're just using a covered device up top, which can be of 10, 15 length, and then using a bare metal stent all the way down, and I've taken these all the way down to the aortic bifurcation, which allows you to still push that septum over, but allows you now still to have access to the visceral branches. If I still have a malperfusion, a static obstruction going out into the visceral branches, then I think you've got to individually, get a wire out into those. You've got to stent those back into the true lumen.
I think if the patient had a malperfusion, as opposed to a malperfusion syndrome, in that situation, I think doing a frozen elephant trunk would be a reasonable thing to do because then it gives you a landing zone.
Yeah. No, I fully agree on acute one.
Right. Okay. So you may disagree. The patient, I did not do this case, but the patient underwent an ascending and a hemiarch. They fenestrated the transverse arch flap, which was felt to be chronic, resuspended the valve. They did an intraoperative intravascular ultrasound of the descending thoracic aorta via the ascending. And they did an abdominal aortogram, which I'm not sure I totally agree with that. And I'll give you some reasons why for that. And so they said that it looked like that that there was good flow in the SMA, or at least adequate flow in the SMA. My concern about that is taking a power injector at 900 psi, putting a angiographic catheter inside the true lumen, and now you're injecting under pressure. You're going to push any true flap moving over. You'll change the dynamics of the flap. That's why I think IVUS is such a great thing to be able to see real time what's going on with your flap. But if you, in my vascular surgery days, Rich Cambray used to say, angiography and dissections can be a trap. Because it will, you'll push the septum over. You'll think that things are wide open when, in fact, as soon as the pressure comes down off that power injection, the septum comes back over, and there's minimal flow going across.
Well, I'd say keep tabs on this guy. He's going to get an aneurysm just distal his left subclavian, particularly if he has more daughters to raise.
I tell you, and I don't want to speak for Mike, but But being old enough to remember back when we used a lot of aortograms to try to manage aortic dissections 30 years ago.
Yeah.
I mean, IVUS and CT gives you a much better lens into what you're trying to see than an aortogram. And that's why, I mean, it seems to me that the information you get from an IVUS in this situation probably would trump anything that you would see, I would think, than in an arteriogram.
Yeah, IVUS is what we would use, and it'd be so much easier to use. And the last comment I'll make about this is I think, like Tom, I would have gone and replaced this guy's arch. That being said, if you don't do a lot of these, and this is what it takes to get a living patient, this is exactly what you should do.
Yeah.
Right. And we'll take a look at his, so he had a follow-up CT before he left. Hemi-arch repair. And actually his SMA looked okay.
Yeah. Yeah, dissections can surprise you on both sides of the surprise,
So look at the
pleasantly
SMA
and
now.
unpleasantly.
So now you can see the SMA completely fills with no...
And as you know, the Stanford people will tell you fix up top always first.
Right.
Yeah.
Everybody, there's not a definitive answer.
And his malperfusion to his left leg got better as well. All from just the proximal operation. All right, another case. So 44-year-old male with hypertension. He's 376 pounds. Presented with the acute onset of chest pain. His brother had a type A dissection 4 years prior. He underwent a PE protocol CT, which initially they thought maybe he had a PE, and unfortunately, you get that timing of the contrast during that. And again, it shows that he has a type A dissection. His echo showed moderate to severe AI, possibly a bicuspid valve. His roots dilated at 5.4. No abdominal pain, lactate's normal, making urine, pulses are intact. In this patient, do you repeat the CAT scan?
Well, show me the
CAT scan.
Show me the CT.
So again, this is just a CT of the chest. You don't have one going down.
He's got type A dissection. I personally, I wouldn't repeat it because he has a type A dissection. What additional information are you really going to glean from this? That he's got type A dissection. He's a young guy. He's got a big root. He's got bad AI. He's going to need his root replaced or fixed in some fashion, and you're going to do what's appropriate distally when you look at his arch. A little worried that there's two brothers that have this.
Right.
It
Bicuspid
doesn't
aorta.
sound Marvinoid at 376 pounds unless he's 8 feet tall.
Right. So, many times we'll get these patients that transfer in, they've had some type of either PE, CT, or another just CT scan with contrast, and the timing of things are not great, and you have a hard time seeing things. And many of these patients, of course, have renal insufficiency, and you're worried about giving them a second dye load. When do you think you need to repeat the CT scan versus just going to the operating room and getting a transesophageal echo or a transthoracic echo to confirm the diagnosis?
So I think, I agree with Mike. I have all the information I need to treat this guy.
Yeah.
If there was something clinically that would concern me that I needed more information, if he had abdominal pain, if he had a lactate, if he had a neurologic presentation, then I'd do it. Dissections, what you see in the scan, if it's not clinically relevant at that point in time, isn't going to change whatever operation you do. So in my opinion, and I think we have enough information from his scan that we have. Granted, it's not perfect, but I think the enemy of good is better.
Gotcha. Okay. All right, so he was taken emergently to the operating room without repeat imaging, had sternotomy, central aortic cannulation via needle access of the true lumen, the kind of double pop technique with TE guidance, basically because he was so big, such a huge guy, digging out that axillary would have been fun. So the plan was to just go all central. When are the times that you'll do that technique?
So as we said earlier, I think certainly in an emergent situation, I think that's a good strategy to have. I don't know if this is my case, but certainly people who are pretty big, and it may be, I've on pretty obese people, I've kind of searched for the axillary artery, and sometimes I have to wonder if I'm sort of in the right place, which is very humbling. So,
Sure.
so I think this is a good strategy for that. And as I said, you can still do antegrade perfusion by directly cannulating the great arteries in the field. It makes for a cluttered field, but it's still very effective. And what was his valve? What did it look like?
So he had moderate AI bicuspid.
Bicuspid, yeah.
And so this gentleman,
And
again,
a big root.
Yeah.
central aortic cannulation, had an ascending hemiarch, had a Bental. Again, he's young, 47, so he got a 27 millimeter onyx mechanical valve. Had some, not surprisingly, post-op pulmonary insufficiency, ultimately extubated, and got discharged about 3 weeks following admission.
That's a success for sure.
Oh yeah, big guy. Last case here. So we've got a 47-year-old male with cocaine abuse, hypertension, a remote gunshot wound to the right lower extremity, developed the acute onset of severe chest pain. The usual, had forgotten to take his blood pressure medicines. He's hypertensive in the 170s. Started on a cardine drip. EKG shows no specific T-wave changes, and he gets a CT scan of the chest.
Well, first thing I see is he started on a cardine drip and nobody's given a beta blocker. So that's that's kind of point number one is I would rarely start cardine without it being on a beta blocker, unless I couldn't put him on a beta blocker for some reason.
Gotcha. All right, so let's take a look at his CT here.
One of the, to Mike's point, one of the rookie moves is if somebody has significant AI, you want to be very careful of getting them on a beta blocker. So I know it's old-fashioned, but even just listening to their chest to see if they have a murmur of aortic regurgitation, that would be a situation where I wouldn't recommend putting them on a beta blocker.
Right.
Gotcha. Okay, so let me play that again. So he's got...
And this is the pitch there, yeah.
So it looks like the tear is in the proximal DTA.
Yeah.
So the ascending looked clean. Let me show it on the sagittal here if we can see. That may be a little bit better. Again, the concern is just distal to the subclavian here, that maybe that's where the entry tear is. And then the rest of it looks okay.
Looks like a big tear.
Correct. All right, so the concern is on his initial CT scan that he's got a large fenestration versus primary entry tear in the proximal descending thoracic aorta. So in these situations, especially either when you're going in there or in situations where you don't see the primary entry tear in the ascending, when you're under circ arrest, you open up the ascending. How do you like to handle those if you're concerned about a retrograde dissection? How do you like to handle those differently?
Yeah, so the trap is if this is a retrograde extension of a type B dissection, and you just replace the ascending aorta, that is a setup for rapid expansion of the arch aneurysm or rupture of the
or bleeding at your original operation.
Like audible bleeding at the end. So I think it's very important to really take the time to inspect not just the arch, but as far as you can see through the arch. And if there was a big fenestration around the level of the subclavian, I think you need to do something.
Yeah.
Whether it's a true elephant trunk or a frozen elephant trunk, or to close that intimal injury.
Okay.
Yeah.
So I guess the questions are for an elephant trunk. What type of graft do you like to use? Do you like to use a stent graft, frozen elephant trunk? Do you like to just use inverted Dacron graft? What's your graft of choice? How long do you like to keep your elephant trunk? And if you're going to do a TVAR, do you like to use that over a wire? Do you just directly place it? How do you like to do that?
So personally, doing a true elephant trunk in an acute dissection that doesn't have an aneurysm is really hard because the operative area is small. Usually the descending aorta is small, and it's very difficult to put the graft in there. And I think that this is an excellent setup for a frozen elephant trunk. And so different people do it different ways. I like to put a wire down under direct vision into the true lumen. Some people will actually use IVUS and go from the femoral artery and put a wire up retrograde and then use that to thread it over. I mean, that's a great way to do it, but I've just under direct vision passed the wire into the true lumen and then passed I use a Gore C-tag device.
Use the 10, 15, 20.
Usually do 10. And I think that, certainly in the early experience, the concern was the risk of paralysis, which was pretty high, for a type A dissection when folks were using a 15 or a longer device. And then it's important to size the aorta. And I look at it right at the level of just beyond the subclavian, and then look around the level of the pulmonary veins to choose what the size. And I still struggle with that.
Do you size it beforehand on the CT, or do you
size it
once you have
beforehand on the CT? Yeah. And try to size. Don't upsize. Truth in sizing.
Sure.
Yeah. Yeah, I think just remember, what are the goals of treating dissections? Cover the primary entry tear, redirect the flow, and those are your goals. And if you don't cover the primary entry tear, I personally almost never do regular elephant trunks anymore, even on aneurysms, because we just have so many better options. And even if you try to do it, besides being hard, it's really not going to seal that entry tear like a graft is going to be.
Unless you cut it out.
Unless you cut it out, but even then, it doesn't do as good a job as I think, because it doesn't expand. It's like a graft expand. And yeah, I do it like you do. I put a wire into direct vision. I put the graft. First time you do this, just realize when you pull the tab in your C-tag, it's not going to expand because it's cold. So don't panic. You just put a little warm saline on it, and it'll expand out.
I think too that it still surprises me how hemostatic that suture line is. I mean, going through your graft, in through the C-tag, into the native aorta, and it's very. And the rookie move is to try to take big bites of the C-tag. You don't need to do that.
Yeah.
And the other thing is, you want to when you deploy your C-tag, you want it to be a little bit further in than a little bit further out, proximally, so that it sits in there well.
Yeah.
Gotcha. All right, so here's the, I think this is the follow-up scan here. And that's what was done, was a frozen elephant trunk with a C-tag device, 10 centimeters long, and a total arch.
Some folks, I know that the folks at Penn have talked about doing a frozen elephant trunk with a extended hemiarch, which is a great operation.
Leaving that little V.
The little V. I figure if you in for a penny, in for a pound, just do the arch.
Yeah, I think that's another one of the examples, though, is you got to do what you can do.
Yeah,
exactly. So I do the same thing, Tom. I go after the whole arch, but then again, I'm reasonably comfortable doing it. Probably if you're out in the community and you don't see this very often, just realize, cover the entry tear, redirect the flow, get a guy out of the operating room.
Yeah. I think other things, that certainly Eric Roselli at the Cleveland Clinic and others have talked about, doing the frozen elephant trunk in zone 2, and then you can either oversew the subclavian origin, or you can even do a fenestration through the
graft,
through the stent graft and into the subclavian. I mean, there's many different ways to skin this cat.
Right. And that's one of the things that we did at Penn many times, is we would do a zone 2 arch debranching and then set that up for either a TVAR with a carotid subclavian bypass, or using a branch thoracic graft into the subclavian. And at least the thought process of that was, it's closer to you, it's more in your face, you avoid the recurrent laryngeal nerve. If there's any bleeding issues, it's right there in front of you, you're not chasing out past the subclavian. And then, we usually wouldn't do that at the same time. Many times we would, bring them back the next day and do the TVAR. Again, it depends upon the patient. And,
got a couple of questions from the
so that was the last slide here. So I think we're going to move to the questions. Can you guys pull up the questions for us?
Well, the first question is, in your experience, what role does pain play in helping to narrowing in on aortic dissection? So I assume is pain a clue? Do they have a dissection?
Sure. So I think So if you look at the big registry series, that it's very common to have severe tearing, ripping, terrible chest pain. And that, if you have it classically, that helps narrow down the dissection. You can have a type A dissection or a type B dissection without any pain.
Right.
That's, I think, about 15% of patients
From IRAD.
don't have any pain from IRAD. And oftentimes, at least classically, the pain that people get is different from coronary pain. That's more of a, well, it's not a pain, it's a pressure, it's a tightness, it's a kind of a gripping sensation, as opposed to the classic pain from a dissection is awful, terrible, ripping, almost histrionic in description.
Yeah, I'm going to die kind of pain.
Yeah.
All right, so next question here is, what are your preferred methods to help avoid misdiagnosing aortic dissection?
Well, that actually goes to the question just before. If you look at the question before, was there's a 50% misdiagnosis for other things like acute coronary syndrome, PE, etc.
Yeah, so I think, at least, when we go back and we have the benefit of hindsight, we see all these patients after the CAT scan's been done, after the diagnosis has been made. But many times you can go back, you can look at the chest x-ray, their mediastinum's widened, they have negative troponins, their EKG doesn't show any specific ST segment elevations or depressions. So usually going back and at least starting off on that point, many patients that had gone down the PE road or gone down acute coronary syndrome road pathways, usually you can go back and say, look at the chest x-ray. It's widened and kind of give you those hints.
That's one of the reasons it's such a lethal disease, because it doesn't, there's a classic presentation, but that's not always, everybody's not always a classic.
Yeah. And most emergency rooms these days have CT scanners, and so the good news is that people nowadays will CT you at the drop of a hat before they do something like give you a thrombolytic most of the time, and that makes life better for us.
Sure.
So, and the other thing I'd say for folks who don't have a lot of experience with dissections are that many times these patients can look deceptively stable.
Yeah.
And I think that all of us have seen people that look pretty stable that suddenly decompensate, and it's very difficult to rescue them. And so I used to tell my residents, anytime somebody has a type A dissection, you got to make believe it's a hand grenade in your hand with the pin pulled out.
Yeah.
The sooner you deal with it, the safer everybody's going to be.
Yeah. And when these people go to the OR, be there when they put them to sleep.
Yeah. That's always a very potentially unstable time.
Well, I think we're nearing the end of our time here. Thank you, everyone, for joining us here on DeBakey CV Live, talking about aortic dissection. We appreciate both of your comments and your years of experience. Thank you very much for joining us this evening.
You're welcome. I think Marvin just called us old, Mike.
Yeah.
But that aside, it was great. It was really a pleasure to be here with you.